Now, it is my huge pleasure to introduce today's speaker. Catherine Gordon is currently the Chief of Adolescent Medicine at Children's in Boston, but be careful with your address book. Starting in September, she will be Physician-in-Chief at Texas Children's, partnering both with that hospital and Baylor. We're honored beyond measure that she is joining us today to talk about DXA in children. Thanks so much for being with us, Catherine.
Thank you so much, Dr. Tosi, and thank you to all of you for being here today. I'm just thrilled to have this opportunity to present at your ECHO session. This is such a wonderful model, and I hope that even after the pandemic, we're going to be able to utilize virtual presentations, cases to be able to teach one another. So again, a real honor and privilege to be here. Let me see if I can get my screen to advance. Here we go. I have no disclosures. So the objectives of my talk,
One second, we're not seeing your slides.
Oh, you're not seeing my slides? Huh. Let's see. Let me try. Share screen. Okay, what about, you can see them?
Yes, I see. Peak bone mass.
Yep, we're good.
Yeah, and I thank you for stopping me there.
No,
So these are the objectives of my talk today. I do direct the adolescent division, but also direct the DXA Center at Boston Children's. In fact, 20 years ago, had the opportunity to found this center modeled after the adult DXA Center next door at Brigham and Women's Hospital, Dr. Meryl LaBeouf, who I'm sure many of you know. So in our practice, our metabolic bone clinic and our DXA Center, we think about bone disorders that can present to a pediatric practice. I'm especially thinking about a tertiary care center such as Boston Children's, Texas Children's, where there are many children and adolescents who are at risk for bone disorders, and both primary and secondary bone disorders, rare diseases, as we're going to talk about. So we're going to think about risk groups. We're then going to think about the indications for DXA in children and adolescents. We're going to talk about its uses, but also the caveats, the limitations, adjustments that we might make in providing an accurate result in a growing child who's a moving target, and thinking about their height, their pubertal development, et cetera. And then I'll briefly go over our philosophy, the Boston Children's way of reporting results. It's been informed by work of the International Society for Clinical Densitometry, or ISCDI. And then lastly, we'll hint at the workup when we find a child has a low bone density. So I always like to start my slides with this. I'm very happy you can see it now. This is bone mass on the y-axis, and then age in years. And I often, when I'm talking to children, young adolescents, I'm drawing this on the exam paper in the room. And I talk to kids about the bone bank. As you can see from the slide, boys have a higher bone mass in general than girls. And during the adolescent years, about half the skeleton should be laid down. But many of the patients I see, especially wearing my adolescent hat, have a chronic disease or receiving a medication that inhibits their bone accrual. So they end up with a lower peak bone mass, which is where bone density plateaus. And unfortunately, we know that both in men and women, there's a loss of bone density as we all get older. So we're trying to maximize that peak bone mass to decrease the risk of osteoporosis. And we're always trying to think about how to assess bone health non-invasively. So we don't want to do a bone biopsy on every child we meet in our metabolic bone clinic. The IRB certainly won't let us do that for clinical research studies. We like to think about how we can get a snapshot of what's happening with their bone health, and again, non-invasively. And some of these points I have already made about the importance of peak bone mass. And I just want to remind you, in a child or an adolescent, as for an adult, the goal of densitometry is to identify those children and adolescents who are at risk for skeletal fragility, to determine whether their bone mass is compromised, how their bone mass compares to age and gender matched peers. And then we can use these measurements to guide and monitor treatments, such as for bisphosphonate treatment in a child with osteogenesis imperfecta. Although I just said to you the rationale for densitometry is the same in children as in adults, the interpretation of bone density results in a child is much more complex because they have a growing skeleton. So our technologists, when they come to the DXA unit, are trying to place that region of interest, and every time the child comes each year, their bone should be a little bit larger. The skeletal geometry should be a little bit different. And so it really takes an expert technologist who knows how to position that child. I always say there's a lot more of a wiggle factor with children. So we have to calm them down, answer their questions, keep them entertained, and try to keep them still. We also have to be mindful of these small skeletal landmarks that change in size and shape. And as they become larger, we can start to adopt some of the measures that are used in adult densitometry. And I'll go through that in a minute. This is a little bit of a busy slide, but just to remind you that in a pediatric center, there are a lot of children who are at risk for bone loss or have threats to bone health in some way. My team has done a lot of work with children or adolescents who have chronic diseases and also happen to have some degree of malnutrition. Anorexia nervosa and eating disorders, a classic example of that. But the work we've done with IBD, with poorly controlled diabetes, how that affects bone health. And then, of course, there are many children with genetic disorders that later we can define as a primary bone disorder, and we use DXA to monitor their health as well. So the two types of disorders, I realize I'm preaching to the choir here, but I want to make sure, especially if there are trainees on the call, that we're all on the same page. The primary disorders of bone, a genetic disease such as a collagen defect, such as Osteogenesis imperfecta, that's a hallmark example of a primary bone disorder. But Ehlers-Danlos, Marfan syndrome, idiopathic juvenile osteoporosis, which becomes a diagnosis of exclusion. And I could go on and on. In the interest of time, I won't, but many of these are rare diseases that present to our bone unit. Our bone units across the country and around the world. And these genetic disorders, as you know, can alter the bone geometry, their structure and strength, which has implications for that positioning of the child when they come to a DXA center. Again, I'm double boarded in adolescent medicine and pediatric endocrine, so I see a lot of adolescents who have secondary bone disorders. In other words, they have juvenile idiopathic arthritis or anorexia. They have a disease or they're receiving a medication that puts their skeleton at risk. And this busy table shows different categories of diseases. Hallie Wasserman and I from Cincinnati Children's wrote a review on bone loss in children and adolescents. And you can see the categories: endocrine, chronic immobility, inflammation, connective tissue disorders, etc. There's a quote that I like to use that osteoporosis is a pediatric disease that manifests primarily during old age. And I think as pediatricians, we always like to think about opportunities for prevention. And certainly osteoporosis is one of those. If we can identify those children and adolescents who are at risk and better define the skeletal deficit with DXA, we can then think about the risk factors and intervene and treat to try to optimize their peak bone mass. So how do we define osteoporosis in a child? So we're always trying to identify a child who has significant skeletal fragility. I always say to my endocrine fellows who are working with in bone clinic, I'm concerned about a low bone mass by DXA, but I'm not going to be as excited about it unless you tell me that that child has evidence of skeletal fragility, multiple fractures or vertebral compression fractures or something, fractures in the setting of minimal trauma. And we're always trying to avoid an overdiagnosis and over-treatment. It's important to remember that among active children and adolescents, 30 to 50% of them are going to sustain at least one fracture. And adolescent boys are slightly more apt to do it than adolescent girls. I can say this because I'm the mother of two boys. They love to get on top of a jungle gym and decide to jump down, I guess, pretend that they're going to fly, and then they break a bone. So if you think about the trauma involved as they were playing Superman coming down from the jungle gym, that could be an appropriate fracture because there was just such an impact, such a stress on the bone. On the flip side, I've had children who were running across the grass to the jungle gym, and so very minimal trauma, and fractured their femur and had an underlying disease that predisposed to skeletal fragility. So it's really important to take that very detailed fracture history. And as we think about osteoporosis, of the history, that fracture history can give us a lot of insight about the clinical diagnosis even before we order the DXA scans or do a laboratory workup. So more about the definition. So I mentioned I've been on consensus panels, as has Dr. Tosi. Thank you for your service, Dr. Tosi, trying to define with the ISCDI what constitutes osteoporosis. So a pathological fracture, a single vertebral fracture, or fracture in the absence of trauma, as I was alluding to in my examples. And a BMD Z-score, bone mineral density Z-score of less than -2, or it can be, the Z-score can be anywhere, but we're concerned about 2 long bone fractures by the age of 10 years, or 3 long bone fractures, really 3 fractures of any kind by early young adulthood, so by 19. So it's really getting at what constitutes multiple fractures. So in a school-age child, 2 fractures should raise a red flag. In a young adult, by the age of 19, 3 fractures would be that threshold of concern. And it's very important to remember, while we use a BMD-Z score of -2, it's important to know that, again, don't treat the DXA scan, treat the patient. We want to make sure to get that history. I'm still going to be worried about a child, even with a Z-score above that, if I see signs of skeletal fragility. Again, that's going to be the most important call is that fracture history. So successes and failures, we're trying to avoid over-treating children. We wouldn't want to start a bisphosphonate, something with side effects that might be used inappropriately. We are able to, my slide advance, identify primary bone disorders, but that the thresholds we've used have been criticized as perhaps being too conservative for high-risk treatment. And maybe there's the possibility of under-treatment if a child has to get all the way to -2 before we initiate a therapy or before they're eligible for an intervention in a clinical trial, then that's a misuse of the threshold. So a single long bone fracture can be sufficient if you have a high-risk patient, one who has many threats to bone health in your history. DXA is the clinical workhorse, if you will, for both children, adolescents, and adults. It's part of a bone health evaluation. It's helpful in establishing a diagnosis in that child with unexplained fractures. It's useful for clinical monitoring. A lot of points we've made We can get a screening to establish a baseline, but it also, the yearly DXA measures can help us to assess for bone accrual, and specifically what happens to the Z-score. Is it maintained, so that's appropriate? Is it positive? Again, the change in the Z-score, which would show bone catch-up, or if it's a negative interval Z-score change, and then that's an evidence of inadequate bone accrual. It's also very helpful for responses to interventions and therapies such as bisphosphonates. So it's a general rule. I'm asked this question a lot. So when in the world should I get DXA scans? So certainly consider these, and these are really guidelines, not policies. A policy is where you have to do something as a clinician, but guidelines to consider DXA scans in the patients with multiple fractures, as I just defined for you, patients with pathological fractures. As a baseline for a patient with a skeletal deficiency state. I'm often asked at what age. In early adolescence, that can be a good time to see where they are as they're on their way towards their peak bone mass. And remember, their medications that can alter bone turnover. Many times the patient has a disease but is also on a medication, so it's a double insult to bone. Be suspicious of a low bone density if there's a strong family history. Remember, 70 to 80% of our bone density is dictated by genetic factors. So that I'm quickly typing in to order the DXA scan, but I start typing more quickly if I hear that there are 3 or 4 family members who have multiple fractures, or who have OI, or have something else that's going to represent a low bone density. Here's someone talking. And in those cases of hypothalamic amenorrhea, after 6 months of amenorrhea, I get DXA scans, just remembering that the menstrual cycle in a young woman should be viewed as a vital sign. It's very important. It's a sign of estrogen deficiency. It could be if they're not having menses.
Well, there's a quick break in slides. Could everyone just please be sure that they are muted? Because we are all hanging on every word and don't want to miss them. Thanks so much.
Thank you, Dr. Tosi. So in 2013, I should go back. In 2007, we had the first Pediatric Physician Development Conference. Many of you here in the audience were part of that. We revised our recommendations in 2013, and lo and behold, led by Dr. Dave Weber, revised the pediatric positions yet again. And you can see in this table, in a school-age child up to the age of 18, the AP spine and the whole body would be our recommended assessment sites. In fact, if you have the software, we recommend the whole body, less head, because we know the skull encompasses about 40% of the skeleton. So if we take the head off, as funny as that sounds, that enables us to better assess for changes over time. Over 18, the AP spine and hip would be our recommendations, similar to what's done in adults. In 2019, the ISCDI had wonderful discussion and accumulated evidence about alternative sites. So the hip is now deemed to be a more informative site than it was previously. The positioning can be more difficult, but in the hands of expert technologists in a pediatric DXA unit, the precision is high. And so we're asking clinicians not to shy away from that site as we have in the past. There are also patients, our OI patients, for example, who have orthopedic hardware. We need to think about the forearm or the lateral distal femur. And this latter site is especially helpful in patients with neuromuscular disease, who are non-ambulatory, who have contractures, who may have the orthopedic hardware where we can't get a whole body or a spinal measurement because it would be positive 5 or 6 because we're measuring the orthopedic rods. So the lateral distal femur can be very helpful for those children. The other point I'll make, patients we have with obesity, sometimes I'll get a forearm measurement because I can't get them on the table. It exceeds the limit of the scanner. A lot of considerations. I assume that most of you on the call know what a Z-score is, but it's a standard deviation score. And certainly a completely normal BMD would be a Z-score of -1 or above. Some of us in the field use -1 to -2 as a slightly low Z-score, and -2, as I mentioned before, is a threshold for low. And again, the reference software enables us to compare bone density to a healthy population, a general population of the same sex, age, and in some accounts, ethnicity. So we've come a long way with our pediatric software, and we can comfortably across the board measure bone density in children down to 5. And depending on which type of scanner you have, you can get some measurements at some sites at the age of 3 or 4. And I want to say just briefly, Dr. Babette Simmel, Dr. Heidi Cockworth at Children's Hospital of Philadelphia, and Dr. Cockworth at Cincinnati Children's have been pioneering getting more normative data for infants. So stay tuned on that. The whole body assessment, I just want to mention briefly to make sure that everyone knows, it affords a soft tissue evaluation in addition to the bone density measurement. And measures of body composition can be especially helpful in understanding what's happening to the muscle bone unit, to fat mass and the lean body mass around bone. And we use it a lot in our clinical research studies, but it can also be helpful if you see a dramatic increase or decrease in bone density to understand what happened to body composition. We would, and I'm saying we as the ISCDI panel would recommend using caution when applying the term low BMD for at-risk children. I alluded to this earlier. Avoid using the term normal because, again, skeletal fragility certainly occurs over and over, even when the Z-score is above -1. And perhaps Dr. David Weber has mentioned this, that maybe thinking about a screening bone density score of less than 0 might be below average, so it's below the mean for age. And but we have to remember the clinical scenario. If that child has ongoing risk to bone health, it would be prudent to repeat the measurement again in a year or 2 years to see if they're tracking appropriately towards their peak bone mass. DXA, as probably most of you know, affords a 2-dimensional measurement of bone density, so the results are confounded by bone size, and it's particularly problematic in growing children. And there are caveats, there are ways to estimate volumetric bone density from this 2-dimensional measurement. 2 methods, the Carter et al., the Kruger et al. Method. I have more experience with the Carter et al., which assumes that bone is a cube and uses an equation to guesstimate that 3rd dimension. Both, however, are useful approaches. I will mention using the Carter method, spinal bone mineral apparent density, or BMOD, had the strongest and most consistent association with upper limb fractures in one study from the UK. And with a lot of research studies, we have used that correction factor. Height is always important to consider. Of course, I have to say that as a pediatric endocrinologist, but it helps us to think about potential confounding of bone measurements by DXA. And we know that in children with short stature or with growth delay, that measurements of the spine and the TBLH, the total body less head, bone density results should be adjusted. And what I just read out to you is actually one of our official ISCD positions. For the spine, we would recommend adjusting either using BMOD, the Carter et al. Method, or the height for HZ score derived in the US from the Centers for Disease Control and Prevention online growth charts. So it's a height Z-score. For the total body less head, we would recommend adjusting for that height for HZ score. And again, all of these tools are online. Dr. Babette Zimmel, who's a friend and very valued colleague to many of us, has really done a lot of work thinking about the relationship between height and bone mineral content and bone mineral density. And she's generated these very helpful reference curves with BMC derived from DXA on the y-axis and height. And you can see how she breaks it out into the mean and plus or minus 1 or 2 standard deviations. She also has an applet online where you can put in the child's bone density measurement, their Z-score, their age and their height, and you can get a height for age adjusted Z-score, which we actually routinely report at Boston Children's in our shorter children. In selected clinical situations, and the one place where I'll use it over and over are patients with multiple hormonal deficiencies, such as a child with a congenital panhypopituitarism or after neurosurgery for a CNS tumor. So in that situation, the adjustment of the BMD for bone age may provide a more accurate interpretation. If a child has a delayed bone age and they have all these hormonal deficits, we can be overestimating the skeletal losses. So we will report both for the chronological age Z-score, as well as the bone age corrected. Over time, we'll do that again a year or two and follow up, and they get closer and closer if we're doing a good job as an endocrinologist keeping up with the hormonal deficits, and importantly, if the patient is able to be compliant with a complex regimen. So what do I report when I put on my DXA hat? I was on call last week here at Boston Children's. Some general points. We try to avoid the term osteopenia in a DXA report because there's a lot of debate as to what that means. To a radiologist, it means they hold up an old-fashioned radiograph and it looks washed out. Or if it's a postmenopausal woman, it could be a T-score within a certain range, and we don't use T-scores in children. The term osteoporosis should also not appear in a DXA report without knowledge of the clinical fracture history. And often we have limited clinical information as for reading scans. Low bone mineral density for chronological age is the preferred term when the BMC, or the aerial BMD-Z score, is less than or equal to -2. And again, T-score should not be used. The T-score is comparing the bone density to what's assumed to be peak bone mass, which is the age of 20 years. And I can't tell you the number of times I've seen a 9 or a 10-year-old who came in with a negative T-score, which of course it's going to be negative if they're 9 or 10. And then we scan them again and we generate a Z-score and their bone density doesn't look as bad. So it's really important that they not be used. It can generate a lot of worry for families as well as the referring clinicians. I've gone through some of these points, but just to make sure I've gotten all of them, tell me about fractures. How old was he or she? What was happening? Again, trying to elicit trauma. Tell me about the family history. I take a detailed history. What about the dental history of the child? As we all know, this is very important in children with OI and some other primary bone disorders, genetic diseases, tooth is bone. And I always tell my patients that your teeth are the only part of the skeleton we can see. The rest of the skeleton becomes a relative black box. What about the growth history early on up through the school age and teenage years? What about puberty? Was it late? Was it early? What about menses? Oh, she hasn't had menses and she's 17. If there's primary amenorrhea, we want to know that. We also want to know if she's only had a couple of menses in her gynecologic years to date. Smoking, alcohol, they can have an adverse effect on bone as well as other tissues. Taking a detailed history, are they skipping meals? Are they concerned about eating? Do they have a healthy relationship with food in general? Or might there be an eating disorder at play? And then again, as we do for all of our clinical histories, is the child or adolescent taking a medication that might remind them that they have a chronic condition. I enjoy adolescents so much. I take the medication history and they tell me they're on prednisone, and this is after the past medical history, and it's like, why are you on prednisone? Oh yeah, I forgot to tell you that I have an arthritis, and then sometimes you have to be flexible and you kind of back step into exactly what's going on. If I identify a low bone density, this is just a very general workup. I'm trying to rule out a systemic disease if it's a child presenting to me who's otherwise healthy with multiple fractures, otherwise healthy with a low bone density. So patients come to our clinic in different ways. I would mention to the audience considering insidious celiac disease. I've been humbled by celiac over the years. There have been many patients who have manifested with simply a low bone density or fractures and had absolutely no GI signs or symptoms. So I always have that in my differential. If you know that a child has a primary disease, thinking of certain severity disease markers, the vitamin D status, whether they have a compensatory hyperparathyroidism, it can be linked to their vitamin D status, of course, calcium, mag, and phosphorus, a bone age, if there's delayed puberty or short stature, and depending on the history and assessment for hypercalciuria and for amenorrhea. I can't say enough about just how important the growth chart is. As you can see, this is a very concerning growth chart where at a young age, this child started losing weight and then the growth plateaued. And if you think about it, the growth curves mirror the bone accrual curve that I showed you early in this talk. So I like to think about them in the same way. And in fact, if I see this kind of curve, I start taking that bone health history to see if that might be a patient where I need to order baseline DXA scans. And just to show you a skeletal image, this was a patient of mine with anorexia nervosa. Here's the L1 through L4 spine, and indeed it was low, was below that threshold of -2. And this is a patient just showing you how I've used DXA who had anorexia nervosa and continued to struggle with her weight, presented to me at about 14.5 and kept losing weight. This is a reference curve and fell below the curve. What's interesting, between the second and third point was prescribed oral contraceptive pills many years ago for quote, bone protection. And we've learned that estrogen deficiency is just one of many hormonal deficiencies in those patients. So just giving estrogen add back doesn't help. They really have to gain weight and improve psychologically. I want to mention, these are sad slides, I know, but patients with chronic juvenile idiopathic arthritis, which can be associated with, it's a very debilitating presentation, joint contractures and swelling, etc., and decreased range of motion. I know Dr. Tosi has seen these patients as a pediatric orthopedist. I wanted to mention them because I think we always have to be very careful in children who are on glucocorticoids in interpreting their spinal BMD-Z scores. These patients who have an inflammatory disease and are on glucocorticoids can have a high prevalence of compression fractures. Children are often amazingly asymptomatic despite having all sorts of medical diagnoses, but compression fractures is an example, and they can play through most anything and camouflage what's going on. And when there's vertebral compression, you can have a spuriously higher bone density. The scanner is seeing that compressed vertebra, and it may be a brittle compressed vertebra, but you're going to get a reassuring Z-score. I would also submit to you that back radiographs are likely underordered in this group. So really thinking about spine health, Dr. Leanne Ward in Ottawa has done a good job helping us to remember about the spine and kids who are at risk. And this is just a compilation of studies that showed completely normal spinal Z-scores, but these were all children with arthritis. And as you can see on the right-hand part of the slide, there were deformities, end-plate deformities noted in a majority, but by our criteria, they had a, quote, normal DXA. There are other methods to assess bone health. The trabecular bone score, or TBS, is a texture index. Dr. Didier Hans in Switzerland was one of the pioneers of this method. It gives us information on bone quality independent of bone mineral density, and it's been very useful in adults as a fracture risk prediction tool. There are more limited data in pediatrics. We used TBS in a series of patients with anorexia a few years ago. Likewise, have used vertebral fracture assessment, or VFA, which allows for a quick spinal measure right when they're there in the DXA unit. And it can be a way to screen for end-plate depression or frank compression fractures. Back radiographs, even if you get a VFA when they're in the DXA unit, if you see something suspicious, the gold standard would be to send your patient for a formal bone radiograph. And you can see here these, I always say in the slide there wasn't a lot to point to, that this would be an example of osteopenia, radiographic osteopenia, because the bones are quite washed out. But as my point below, I would never say osteopenia in the DXA report. The finding of one or more vertebral compression or crush fractures, as it's often called in the UK, is indicative of osteoporosis, but remembering that the Z-score above -2 does not preclude the possibility of osteoporosis or increased skeletal fragility. So Dr. Tusi, I'm going to stop. I have an interesting case to share, but thought I might pause here if there are any questions, or I can proceed on with my case.
Absolutely. So let's do this. As we've done in the past, we're going to take